Welcome to Section 5. This section has two parts. In the first part, I will be providing an overview of acid-base physiology and pathophysiology. And in the second part, I will be going through specific examples of acid-base disorders. Let's get started. There are two types of acid that are produced by the body: volatile acids and non-volatile acids. The major physiologic volatile acid is carbon dioxide. It's volatile because it's a gas that's easily removed from the circulation during normal respirations. As you'll recall, CO2 is produced from cells during aerobic metabolism and freely diffuses into the circulation. So this represents peripheral tissue, and it's producing CO2. This is the plasma, and this is a red blood cell. Once in the circulation, carbon dioxide can diffuse into red blood cells and be converted to bicarbonate through the following reaction. Remember, the enzyme that catalyzes this reaction is carbonic anhydrase, or Ca for short. The bicarbonate can then be transferred from the cytoplasm to the plasma through the bicarbonate chloride antiporter. The bicarbonate is taken from the periphery back to the lungs, where these reactions occur in reverse, ultimately allowing the lungs to expel carbon dioxide. Throughout this section, I will be referring to this equation a lot. So if you don't have it memorized yet, hopefully you will by the end of the section. It's incredibly important for understanding acid-base principles. Non-volatile acids include several molecules, such as phosphoric acid, sulfuric acid, lactic acid, and ketoacids. These are normal products of metabolism, but they may also include other acids that can be ingested, like salicylic acid, which is the active ingredient in aspirin. It shouldn't be too hard to understand that significant alterations in acid concentrations, or pH, can be detrimental to the normal human physiology. So one way of mitigating these pH changes is through buffer systems. A buffer is simply an acid and its conjugate base, and it works by preventing significant changes in pH upon the addition or removal of acid. So it helps mitigate significant changes in pH. The Henderson-Hasselbalch equation is shown here, which is the pH equals 6.1 plus the log times bicarbonate divided by 0.03 times the partial pressure of carbon dioxide. This can be useful for determining the pH of a buffer system. In this context, it has been formatted to calculate the pH using the most common physiologic buffer, carbon dioxide and bicarbonate. There are three major buffer systems that you need to be aware of for step 1, and they include extracellular, intracellular, and urinary buffers. The Henderson-Hasselbalch equation that we just discussed happens to be adjusted for determining the pH of the major extracellular buffer, carbon dioxide and bicarbonate. This may seem confusing that carbon dioxide is the conjugate base of bicarbonate, but if you remember the equation, CO2 plus water forms carbonic acid, and then bicarbonate plus acid. This makes sense. When bicarbonate binds a hydrogen ion, it gets converted to carbonic acid, and then rapidly dissociates into carbon dioxide and water. So you can see that bicarbonate is actually the conjugate base of carbonic acid, but these are directly related to carbon dioxide. Because carbonic acid so rapidly gets converted to either carbon dioxide or water, carbon dioxide can be used as a surrogate to measure carbonic acid. Another minor extracellular buffer you need to be aware of is inorganic phosphate. Recall that inorganic phosphate can bind up to 3 hydrogen ions. Likewise, phosphoric acid, or H3PO4, can lose 3 hydrogen ions. In this way, inorganic phosphate is useful in acting as a buffer because it can easily donate hydrogen ions during an alkalosis or bind up hydrogen ions during an acidosis. Okay, the major intracellular buffers include organic phosphates like ATP, ADP, and AMP. It also includes things like hemoglobin and deoxyhemoglobin. If you know that inorganic phosphate is an extracellular buffer, it shouldn't be too hard to remember that ATP, ADP, and AMP all contain inorganic phosphate, so they behave similarly to the extracellular buffer I just described. In red blood cells, hemoglobin and deoxyhemoglobin, and this is just a form of hemoglobin that doesn't have oxygen bound to it, combine hydrogen ions as carbon dioxide gets converted to acid and bicarbonate. Okay, the major urinary buffers include ammonia and inorganic phosphate, or more commonly, hydrogen phosphate. Let's draw this out on a blank slide. This is the proximal convoluted tubule. Here's the loop of Henle, and this is an alpha intercalated cell in the collecting duct. As you recall, the proximal convoluted tubule has a sodium-hydrogen antiporter. This is responsible for secreting acid into the lumen of the nephron, as I've drawn here. So this is the lumen, this is the interstitium. Throughout the nephron, the amino acid glutamine, just write a G for short, can be converted to ammonia, or NH3. Ammonia can then be secreted into the lumen of the nephron and act as a buffer by binding free hydrogen ions. So ammonia gets converted to ammonium, or NH4. Hydrogen phosphate is a byproduct of metabolism and is freely filtered by the glomerulus. Once in the lumen of the nephron, it can also bind free hydrogen ions. So hydrogen phosphate gets converted to dihydrogen phosphate. Remember, hydrogen is secreted into the lumen of the nephron through hydrogen ATPases in the alpha intercalated cell, as well as hydrogen potassium ATPases. So you can see that ammonia and hydrogen phosphate are important buffers in the nephron and allow the kidneys to secrete excess hydrogen ions without drastically altering the pH of the urine. And this makes sense. If a buffer system didn't exist here, then the nephron would rapidly become damaged during an acidosis. It's important to note that during an acidosis, the synthesis of ammonia from glutamine is greatly enhanced, which allows the kidneys to secrete additional acid. Okay, so here's a question. How would the concentration of ammonium in the urine change in a patient with diabetic ketoacidosis, or DKA? So I'll write this question up here. Patients with DKA have very low levels of insulin. A lack of insulin results in lipolysis, which is just the breakdown of triglycerides into glycerol and free fatty acids. The free fatty acids can be used to make ketoacids, which can be metabolized for energy. The accumulation of ketoacids results in a metabolic acidosis, and the nephron begins to produce more ammonia from glutamine, and this helps increase the excretion of acid. So you can see that ammonia gets converted into ammonium and is lost in the urine, ultimately resulting in increased concentration of ammonium in the urine. My focus here is not on the pathophysiology of DKA, so if that was confusing, go watch the chapter on endocrinology where we discuss DKA in more detail. Making an acid-base diagnosis is perhaps one of the most commonly tested subjects for step 1 when it comes to physiology. I guarantee you will see this all throughout QBanks, and you'll probably have a couple acid-base questions on your actual exam. So now I'd like to discuss the key steps in making a diagnosis for acid-base abnormalities. As I go through these examples, I'd like to refer you to figure 4.8 from your text, which is the flow diagram here, and can be helpful in keeping these acid-base problems straight. Anytime I think about an acid-base problem, I like to use the equation carbon dioxide plus water reacts to form carbonic acid, which then gets converted into bicarbonate and hydrogen. The left side of the equation, carbon dioxide, is regulated by the respiratory system, and the right side of the equation, bicarbonate, is regulated by the kidneys. Visualizing the changes that occur with this equation is key to understanding the 4 major acid-base abnormalities: a respiratory acidosis, metabolic acidosis, respiratory alkalosis, and metabolic alkalosis. There are really only two steps in making a diagnosis. The first step is checking the pH. Knowing the pH will help you determine if there is an acidemia or an alkalemia, which narrows your differential down to 2 of 4 possibilities. After that, you can then check the carbon dioxide and bicarbonate concentrations. Knowing the concentration of carbon dioxide and bicarbonate will help you further narrow your differential down to 1 of 2 possibilities. Let's take, for example, a respiratory acidosis. We've checked the pH and it's lower than 7.35, so we know the patient has an acidosis. We also know there are only 2 types of acidemias, so we now need to determine if the patient has a respiratory acidosis or a metabolic acidosis. If we check the carbon dioxide and we see that it's elevated, we have our answer. The patient has a respiratory acidosis. This makes sense. If you stop breathing, then the lungs can no longer remove carbon dioxide from the circulation, so carbon dioxide begins to accumulate throughout the body. If you remember this equation, you can see that carbon dioxide gets converted to acid, which lowers the pH and causes an acidosis. So pretty straightforward. Determine the pH and then measure the carbon dioxide and bicarbonate, and you should be able to arrive at a diagnosis of the primary acid-base disturbance. Now let's walk through the other examples. Let's say the patient now has a metabolic acidosis. We've checked the pH and it's less than 7.35, so we know the patient has an acidosis. We also know there are only 2 types of acidemias, so we now need to determine if the patient has a respiratory acidosis or a metabolic acidosis. Let's say we first check the carbon dioxide and we see that it's low. This should tip us off that there is not a respiratory acidosis, because the carbon dioxide would have to be high in order for this to be true. We also know that the pH is low, so we shouldn't even be considering a respiratory alkalosis. By understanding these 2 things, we should already have a diagnosis even before checking the concentration of bicarbonate. But let's say we check the bicarbonate and it's low. We now have our answer. The patient has a metabolic acidosis. A metabolic acidosis can be due to either excessive loss of bicarbonate, or it can be due to an accumulation of non-volatile acids, such as keto acids. In either case, this results in a decrease in plasma bicarbonate concentrations. This makes sense. If too much non-volatile acid begins to accumulate in the blood, then it will rapidly consume the bicarbonate buffer, and there will be excess free hydrogen ions, which will lower the pH and cause an acidosis. Let's say the patient has diarrhea and is losing excess bicarbonate. Again, the decreased bicarbonate means there is more free hydrogen ions, which will lower the pH and cause an acidosis. Let's say the patient now has a respiratory alkalosis. We've checked the pH and it's greater than 7.45, so we know the patient has an alkalosis. We also know there are only 2 types of alkalemias, so we now need to determine if the patient has a respiratory alkalosis or a metabolic alkalosis. Remember, the second step in making a diagnosis is checking the carbon dioxide and the bicarbonate concentrations. So if we measure the carbon dioxide to be low, we have our diagnosis, a respiratory alkalemia or alkalosis. This makes sense. If a patient begins to hyperventilate, then the lungs will blow off too much carbon dioxide. If we understand the law of mass action, then we can see that the drop in carbon dioxide will cause the equation to shift to the left, resulting in decreased free hydrogen ions in the plasma and a subsequent rise in pH, or an alkalosis. Let's say the patient now has a metabolic alkalosis. We've checked the pH and it's greater than 7.45, so we know the patient has an alkalosis. We also know there are only 2 types of alkalemias, so we now need to determine if the patient has a respiratory alkalemia or a metabolic alkalemia. We measure the carbon dioxide and bicarbonate concentrations and find that the carbon dioxide concentration is high. This should tip us off that there is not a respiratory alkalosis, because the CO2 would have to be low in order for this to be true. We also know that the pH is high, so we shouldn't even be considering a respiratory acidosis. By understanding these two things, we should already have a diagnosis even before checking the concentration of bicarbonate. But let's say we check the bicarbonate and it's high. We now have our answer. The patient has a metabolic alkalosis. This makes sense. As the excess bicarbonate accumulates in the blood, it reacts with and consumes the free acid, resulting in a decrease in free hydrogen ions. Over time, there is more bicarbonate than free hydrogen ions, which causes the pH to rise, resulting in a metabolic alkalosis. Now that you have a basic understanding of the primary acid-base disturbances, I'd like to revisit and talk about each of the disorders in more detail. The next steps in the flow diagram help you further understand the big picture of a primary acid-base disturbance. For example, in a respiratory problem, it's important to know if the disturbance is an acute or chronic process. In a metabolic acidosis, it's important to know if the anion gap is elevated or normal. In every primary acid-base disturbance, it's also important to know if there is adequate compensation from the respiratory system or the renal system. Let's again look at respiratory acidosis and walk through this process. So we've checked the pH as well as the carbon dioxide and bicarbonate, and I've determined that the patient has a respiratory acidosis. At this point, we need to determine if it's an acute or chronic process. An acute respiratory acidosis generally means the problem has been going on for less than 8 hours. A chronic respiratory acidosis typically refers to greater than 24 hours. The key to understanding an acute versus chronic respiratory acidosis is determining if the kidneys have adequately compensated for the acid-base disturbance. This is because renal compensation takes time, specifically 24 to 48 hours. In other words, renal compensation only occurs in a chronic respiratory acidosis, not an acute respiratory acidosis. If there is an acute respiratory acidosis, then the lungs can no longer adequately remove carbon dioxide from the circulation. So carbon dioxide begins to accumulate throughout the body. From our equation, we can see that the carbon dioxide gets converted to acid, which lowers the pH and causes an acidosis. The normal compensatory response in this case would be for the kidneys to increase the reabsorption of bicarbonate. This makes sense. The increased bicarbonate would be able to buffer the free hydrogen ions, which would reduce the overall free hydrogen ion concentration in the blood. This would allow the pH to begin to normalize and ultimately reduce the severity of the respiratory acidosis. Okay, let's pull up a blank screen so I can show you how renal compensation occurs. This is the proximal convoluted tubule of the nephron. This is the lumen, and this is the interstitium. Remember, within the cells of the proximal convoluted tubule, carbon dioxide and water react to form bicarbonate and hydrogen. The bicarbonate is reabsorbed, and the acid is secreted through the sodium hydrogen antiporter. Normally, filtered bicarbonate reacts with the hydrogen ions that are secreted to form carbon dioxide and water. The carbon dioxide and water diffuse into the cells of the proximal convoluted tubule, and the process starts all over again. So you can see that free hydrogen ions in the lumen of the nephron are necessary in order for bicarbonate to be reabsorbed. If the hydrogen ion concentration is reduced, more bicarbonate passes by the proximal convoluted tubule and ultimately gets excreted into the urine. If the hydrogen ion concentration is increased, then it's able to react with the bicarbonate more frequently, which ultimately results in an increased reabsorption of bicarbonate. It's also important to note that the basolateral side of the cells within the proximal convoluted tubule have a hydrogen-potassium antiporter. This allows hydrogen ions to enter the cell and potassium to leave the cell. During a respiratory acidosis, excess carbon dioxide accumulates in the blood and gets converted to hydrogen ions. The hydrogen ions enter the proximal convoluted tubule through this pump, which ultimately results in additional hydrogen ions entering the lumen of the nephron. As I just mentioned, if there is more hydrogen present, then the reabsorption of bicarbonate increases. So you can see that in a respiratory acidosis, the reabsorption of bicarbonate is increased. And this process I've just described is the basis for renal compensation. Remember, this process normally takes around 24 to 48 hours, which explains why renal compensation only occurs in chronic respiratory conditions. As I described earlier, the kidneys can also compensate for acidosis by increasing the secretion of ammonium and dihydrogen phosphate, which helps increase the excretion of acid during an acidosis. So again, from the flowchart, you can see that the major difference between an acute and chronic respiratory acidosis is pH and the concentration of bicarbonate. In an acute respiratory acidosis, the pH is lower than a chronic respiratory acidosis because there is more free hydrogen ions. Likewise, the bicarbonate concentration in an acute respiratory acidosis will likely be normal or slightly elevated. This is because the kidneys haven't had time to reabsorb additional bicarbonate. In a chronic respiratory acidosis, the kidneys have had sufficient time to reabsorb additional bicarbonate, so the bicarbonate concentration should be elevated. Before moving on, I'd like to discuss one more concept. Some students struggle with understanding how excess carbon dioxide in a respiratory acidosis can cause an acidosis. After all, from this equation, we can see that carbon dioxide gets converted into equal concentrations of an acid and a base. It can be deceptive to think, oh, the bicarbonate will just bind up the acid and no change in pH will occur. But that's not what happens. Bicarbonate normally acts as a buffer by binding free hydrogen. But in order for this to occur, carbonic acid would have to form, which would just shift the equation back to the left. So you can see that in the presence of elevated carbon dioxide concentrations, the reverse reaction is unfavorable, which means the bicarbonate ends up floating around in the blood and is unable to act as a buffer by binding up excess hydrogen ions. Ultimately, the excess carbon dioxide gets converted to equal concentrations of bicarbonate and free hydrogen ions, which explains why bicarbonate levels are normal, but the pH is low, resulting in an acidemia. Okay, moving on to respiratory alkalosis. So we've checked the pH as well as the carbon dioxide and bicarbonate and have determined that the patient has a respiratory alkalosis. At this point, we need to determine if it's an acute or chronic process. From this equation, we can see that hyperventilation results in low CO2. The drop in CO2 will cause the equation to shift to the left, resulting in decreased free hydrogen ions in the plasma and a subsequent rise in pH, or an alkalosis. The normal compensatory response in this case would be for the kidneys to decrease the reabsorption of bicarbonate. This makes sense. The decreased bicarbonate would allow the free hydrogen ion concentration to rise. This would allow the pH to begin to normalize and ultimately reduce the severity of the respiratory alkalosis. So let's draw this out on the next slide. This is the proximal convoluted tubule of the nephron, this is the lumen, and this is the interstitium. Again, within the cells of the proximal convoluted tubule, carbon dioxide and water react to form bicarbonate and hydrogen. The bicarbonate is reabsorbed and the acid is secreted through the sodium hydrogen antiporter. The filtered bicarbonate reacts with the hydrogen ions that are secreted to form carbon dioxide and water. The carbon dioxide and water diffuse into the cells of the proximal convoluted tubule, and the process starts over again. Remember, the basolateral side of the cells within the PCT have a hydrogen-potassium antiporter, and this allows hydrogen ions to enter the cell and potassium to leave the cell. During a respiratory alkalosis, a drop in CO2 results in a left shift and decreased free hydrogen ions in the blood. The drop in hydrogen ions means less hydrogen enters the cell through this pump, which ultimately results in decreased hydrogen ions entering the lumen of the nephron. As I mentioned before, if there is less hydrogen present in the lumen of the nephron, then less bicarbonate is able to be reabsorbed. In this way, I kind of think of hydrogen ions as a net that catches the bicarbonate and allows it to be reabsorbed into the blood. So you can see that in a respiratory alkalosis, the reabsorption of bicarbonate is decreased. And this process I've just described is the basis for renal compensation. So again, from the flow chart, you can see that the major difference between an acute and a chronic respiratory alkalosis is the pH and the bicarbonate concentration. In an acute respiratory alkalosis, the pH is higher than a chronic respiratory alkalosis because there is a greater drop in free hydrogen ions. So decrease hydrogen. Likewise, the bicarbonate concentration in an acute respiratory alkalosis will be normal. So normal bicarb. It could also be slightly decreased. And this is because renal compensation has not yet occurred. In a chronic respiratory alkalosis, the bicarbonate concentration in the blood will likely be decreased. This is because the kidneys are secreting less free hydrogen ions, which means the reabsorption of bicarbonate from the nephron decreases. The increased bicarbonate excretion that occurs allows the free hydrogen ion concentration in the blood to rise, which ultimately reduces the severity of the respiratory alkalosis. Moving on to metabolic acidosis. So we've checked the pH as well as the carbon dioxide and bicarbonate and have determined that the patient has a metabolic acidosis. At this point, we need to determine if the anion gap is elevated or within normal range. Before we move on, why don't I take a second to pull up a blank slide and explain what an anion gap means. So I'll draw a box here and split it in half. The left side of the box represents the majority of cations in the extracellular space. In this case, sodium is the primary extracellular cation. The right side of the box will represent the majority of the extracellular anions, which are chloride and bicarbonate. The anion gap is calculated by subtracting chloride and bicarbonate from sodium. And a normal anion gap is between 8 and 12 milliequivalents per liter. Conceptually, an anion gap refers to unmeasured anions in the blood, which I'll explain more in a second. So in this case, let's take roughly normal values and plug them into the formula. Let's say the sodium concentration is 138, chloride is 105, and bicarbonate is 25. If we plug these numbers into the equation, we get 138 minus 105 plus 25, or 138 minus 130, which is 8. Recall that normal is between 8 and 12. So you can see that this patient has a normal anion gap. Now let's say the same patient has a metabolic acidosis. Let's say the sodium concentration has stayed the same. The bicarbonate has decreased to 15, and the chloride has increased to 115. If we plug these numbers in, we get 138 minus 115 plus 15, or 138 minus 130, which again is 8, which is a normal anion gap. So you can see that as the bicarbonate decreased by 10, the chloride also increased by 10, and ultimately the anion gap remained the same. This would be considered a non-anion gap, or a normal anion gap metabolic acidosis. Now let's say the patient has another metabolic acidosis. This time the sodium is again 138, the bicarbonate is 15, and the chloride is 105. If we plug these numbers in, we get 138 minus 105 plus 15, or 138 minus 120, which is 18. You can see that as the bicarbonate decreased by 10, the chloride did not increase. It stayed the same. In this case, there's an increase in unmeasured anions like lactate, phosphate, sulfur, or others. This makes sense. If bicarbonate is decreasing and chloride is not changing, then another anion must be accumulating somewhere to account for the loss of the negative charge. In other words, the electroneutrality of the body must stay relatively constant. So if a negatively charged bicarbonate anion is lost, then another anion in the form of sulfur, phosphate, lactate, or others must increase. If this didn't occur, the body would quickly become positively charged, which would disrupt normal homeostasis. Before we move on, I'd like to quickly draw the nephron and remind you of how bicarbonate and chloride are handled. So this is the proximal convoluted tubule. This is the thick ascending limb. Here's the distal convoluted tubule. And this is an alpha and a beta cell. Within the proximal convoluted tubule, there is a luminal bicarbonate chloride antiporter, like this. In the thick ascending limb, there's a luminal NKCC channel, which reabsorbs sodium, potassium, and 2-chloride. In the distal convoluted tubule, there's a luminal sodium chloride symporter. In the alpha cell, there's a basolateral bicarbonate chloride antiporter. And in the beta cell, there's a luminal bicarbonate chloride antiporter. So you can see that in the proximal convoluted tubule and medulla, bicarbonate and chloride are handled completely opposite of one another. For example, if bicarbonate is being secreted into the lumen by beta cells, then chloride must be getting reabsorbed. This way of handling bicarbonate and chloride explains a normal anion gap metabolic acidosis. As negatively charged bicarbonate decreases, the negatively charged chloride increases. Likewise, the thick ascending limb and the distal convoluted tubule show that chloride can be handled independently from bicarbonate. If bicarbonate concentrations in the blood decrease, the sodium-potassium 2-chloride pump in the thick ascending limb and the sodium chloride symporter in the distal convoluted tubule could potentially be downregulated. This would ultimately result in a decrease in bicarbonate without an increase in chloride, which explains how an anion gap metabolic acidosis could occur. The main reason we care about an anion gap is because it helps narrow down the differential into possible causes of metabolic acidosis. For example, many students use the mnemonic mud piles to remember the potential causes of an elevated anion gap metabolic acidosis. M stands for methanol, U stands for uremia, D stands for diabetic ketoacidosis, P stands for propylene glycol, I stands for iron tablets or isoniazid, L stands for lactic acidosis, E stands for ethylene glycol, and S stands for salicylic acid. Likewise, the mnemonic HARD-AS is used to remember the causes of a normal anion gap metabolic acidosis. H stands for hyperalimentation, A stands for Addison's disease, R stands for renal tubular acidosis, D stands for diarrhea, A stands for acetazolamide, S stands for spironolactone, and the final S stands for saline infusion. Unfortunately, you will need to memorize these. It's important for step 1 and will definitely help you get more questions right throughout Q-Banks and hopefully on your actual exam. In addition to determining the anion gap, it's also important to determine if the lungs are adequately compensating for the metabolic acidosis, which is done using the Winters formula. In review, the Winters formula is the partial pressure of carbon dioxide equals 1.5 times the bicarbonate plus 8 plus or minus 2. The partial pressure of carbon dioxide refers to the predicted partial pressure of carbon dioxide in the blood, and bicarbonate refers to the measured concentration of bicarbonate in the blood. How about I go through an example to make this clear? Let's say a patient has a metabolic acidosis and we're trying to find out if the lungs are adequately compensating. So remember the equation, carbon dioxide plus water reacts to form carbonic acid, bicarbonate, and acid. In a metabolic acidosis, we know that the bicarbonate concentration is low, resulting in excess free hydrogen ions. So a normal compensatory response from the lungs would be to blow off additional carbon dioxide, which would cause a left shift and reduce the concentration of acid in the blood. In other words, the normal respiratory response in a patient with a metabolic acidosis should be hyperventilation. Let's say we measure the bicarbonate in the blood, which is 14 milliequivalents per liter, and the partial pressure of carbon dioxide is 40 millimeters of mercury. A normal bicarbonate concentration is 22 to 28, and a normal partial pressure of carbon dioxide is 33 to 44. So obviously we expect the bicarb to be low in a patient with a metabolic acidosis, but now we need to know if the partial pressure of carbon dioxide is where it should be for this patient. As you can see, the partial pressure of carbon dioxide is 40, which is within the normal reference range. But before we even use the Winters formula, this should be concerning because although a partial pressure of carbon dioxide of 40 is technically within the normal reference range, this is not a normal response for a patient with a metabolic acidosis. Normal for a patient with a metabolic acidosis should be hyperventilation, and therefore we'd expect a lower than normal partial pressure of carbon dioxide. Let's plug in the numbers and see what this means. So using this equation, you get 1.5 times 14 plus 8, which equals 29. 29 plus or minus 2 gives us a range of 27 to 31. This means that given the measured bicarbonate concentration, we would predict that the patient's partial pressure of carbon dioxide should be between 27 and 31 millimeters of mercury. Now we need to compare this calculated reference range with what we were given. We can see that our given value of 40 millimeters of mercury is obviously higher than our predicted value of 27 to 31. So if the measured partial pressure of carbon dioxide is greater than the predicted partial pressure of carbon dioxide, there is inadequate respiratory compensation. In other words, there is a mixed acid-base disorder, a metabolic acidosis, and a concomitant respiratory acidosis. This is how the Winters formula is useful. It helps predict what a normal reference range of partial pressure of carbon dioxide should be and tells us how the lungs should be behaving during a metabolic acidosis. As I've just shown, if the measured partial pressure of carbon dioxide is greater than the predicted partial pressure of carbon dioxide, then there is a concomitant respiratory acidosis. If the measured partial pressure of carbon dioxide is less than the predicted partial pressure of carbon dioxide, then there's a concomitant respiratory alkalosis. If the measured partial pressure of carbon dioxide is within the predicted reference range, then the lungs are adequately responding and there's an isolated metabolic acidosis with no respiratory acid-base abnormality. It's important to know that any type of mixed acid-base disorder can occur, but other variations of mixed acid-base disorders are very unlikely to show up on step 1. So for example, a mixed metabolic acidosis and metabolic alkalosis is possible, but it's beyond the scope of step 1. Otherwise stated, any mixed disorder is possible, but aside from a metabolic acidosis with a concomitant respiratory abnormality, other variations are unlikely to show up on step 1, so I'm not going to discuss them any further. So again, from the flowchart, you can see that there are 4 steps we need to think about with a metabolic acidosis. First, measure the pH. Second, determine the bicarb and the partial pressure of carbon dioxide. If the bicarbonate's low, then we know it's a metabolic acidosis. Third, measure the anion gap. This will help us narrow down the differential to mud piles or hard-ass. Last, plug the measured bicarbonate concentration into the Winters formula and compare the predicted partial pressure of carbon dioxide range to the measured partial pressure of carbon dioxide. If the measured PCO2 is less than the predicted PCO2, then there's a concomitant respiratory alkalosis. If the measured PCO2 is within the predicted reference range, then the lungs are adequately responding and there's an isolated metabolic acidosis with no respiratory acid-base abnormality. Before moving on to metabolic alkalosis, I'd like to remind you that both the kidneys and the lungs work together to reduce the severity of the metabolic acidosis. The lungs will normally hyperventilate and reduce carbon dioxide, and the kidneys will normally increase the secretion of ammonium and dihydrogen phosphate and increase the reabsorption of additional bicarbonate. This makes sense. The excess acid in the PCT will allow for greater reabsorption of bicarb, as I showed earlier, and the excess acid secretion in the kidneys will allow hydrogen phosphate and ammonia to bind up the free hydrogen, which can then be excreted in the urine. Okay, moving on to metabolic alkalosis. At this point, we've determined the pH and the bicarb, as well as the partial pressure of carbon dioxide, and found that the patient has a metabolic alkalosis. As excess bicarbonate accumulates in the blood, it reacts with and consumes the free acid, resulting in a decrease in free hydrogen ions. Over time, there is more bicarbonate than free hydrogen ions, which causes the pH to rise, resulting in a metabolic alkalosis. The normal compensatory response is hypoventilation, which results in the retention of carbon dioxide. A right shift will cause the carbon dioxide to be converted into hydrogen and lower the pH, which is the basis for respiratory compensation. It's important to know that the Winters formula cannot be used for a metabolic alkalosis. This is because the lungs are actually more sensitive and responsive to a metabolic acidosis than a metabolic alkalosis. So the changes in ventilation that occur during an acidosis don't parallel an alkalosis. Just like in other acid-base disorders, the kidneys respond to the alkalosis by regulating the reabsorption of bicarbonate. Specifically, they work by decreasing the secretion of hydrogen into the lumen of the nephron, which ultimately reduces the reabsorption of bicarbonate. This makes sense. The body doesn't want to reabsorb more bicarbonate when there's already excessive bicarbonate in the blood. Finally, it's important to measure the urine chloride, which helps us determine the cause of the alkalosis, which can aid in determining proper treatment. So there are 4 major causes of a metabolic alkalosis that you need to know for step 1, and they include loop diuretics, antacid use, vomiting, and hyperaldosteronism. I'm going to walk through each of these and explain how the urine chloride is useful. Let's pull up a blank screen so I can show you what's going on here. First, we're going to discuss loop diuretics. This is the thick ascending limb of the nephron. This is the interstitium, and this is the lumen. Recall that there is a sodium-potassium chloride pump on the luminal surface of the thick ascending limb. This is sometimes referred to as the NKCC channel. Also recall that there are other channels on the basolateral side of the thick ascending limb that allow the interstitial reabsorption of these electrolytes. Remember from pharmacology that loop diuretics, like furosemide or torsemide, block the NKCC channel. The idea here is that initially, the chloride will be lost in the urine as a result of blocking this channel. So we'd expect the urine chloride to initially be high. However, over time, the chloride concentration in the blood would begin to decrease due to excessive excretion. Ultimately, the decreased chloride in the blood would result in less filtered chloride and therefore less chloride lost in the urine. So patients who are first starting a regimen of loop diuretics will have a high urine chloride. But chronic use of loop diuretics will result in a low urine chloride. Chronic use of a loop diuretic could also cause excessive loss of water, making the patients hypovolemic. So it makes sense that these patients would be responsive to an infusion of saline. As I continue discussing the other disorders, you'll see an important pattern here. Anytime a patient has a low urine chloride, they will also be hypovolemic and therefore responsive to an infusion of saline. This is why you'll often see the phrase saline responsive or saline unresponsive metabolic alkalosis. In other words, a low urine chloride is synonymous with a saline responsive metabolic alkalosis, and a high urine chloride is synonymous with a saline unresponsive metabolic alkalosis. So the hypovolemia results in increased renin, which increases aldosterone. Recall that aldosterone increases the secretion of acid, which causes a metabolic alkalosis. Antacids also cause a saline-responsive metabolic alkalosis by working in a similar way to loop diuretics. Remember that antacids contain calcium carbonate. When the calcium dissociates, it can cause hypercalcemia. And hypercalcemia actually blocks the NKCC channel. In this way, hypercalcemia from antacids induces a diuresis similar to a loop diuretic. So the pathophysiology of an antacid-induced metabolic alkalosis is very similar to loop diuretic use. Okay, now we're going to discuss vomiting. Recall that the stomach contains hydrochloric acid, or HCl. When you vomit, you lose both acid and chloride. The loss of acid results in a metabolic alkalosis. If the body is losing chloride through vomit, then the kidneys will attempt to increase the reabsorption of chloride, which means the chloride detected in the urine will be low. Because the patient is vomiting, he or she will lose water and become hypovolemic. So this patient would have a saline-responsive metabolic alkalosis. Okay, finally, we're going to discuss hyperaldosteronism. Hyperaldosteronism can cause a high urine chloride and therefore a saline unresponsive metabolic alkalosis. So this is an alpha intercalated cell in the collecting duct. This is the lumen of the nephron, and this is the interstitium. Recall that carbon dioxide and water combine to form hydrogen and bicarbonate. The bicarbonate is exchanged for chloride, and the intracellular chloride can then move into the lumen of the nephron. Also recall that aldosterone works to increase the secretion of acid in the alpha intercalated cell by upregulating these pathways. As the secretion of acid is increased, you can see that the reabsorption of bicarbonate must also increase, which is responsible for the metabolic alkalosis. In order for this to occur, the chloride must be exchanged and is ultimately lost in the urine. So in a patient with hyperaldosteronism, you'd expect the urine chloride to be high. Also recall that aldosterone increases the reabsorption of sodium and water, so we'd expect this patient to be euvolemic or slightly hypervolemic. So as we can see, that it wouldn't make much sense to give a bolus of saline in a patient whose blood volume is normal or slightly elevated. This is why patients with hyperaldosteronism have a high urine chloride metabolic alkalosis and are unresponsive to saline. Okay, before wrapping up this section, I'd like to take a second to discuss the Davenport diagram, which is shown in figure 4.9 from your text. This diagram is a good summary of all the acid-base abnormalities, but it's also an important diagram to be able to interpret. As you can see, the x-axis is the arterial blood pH. The y-axis is the concentration of bicarbonate in the plasma, and intersecting red lines represent the partial pressure of carbon dioxide. We've labeled the different colored regions with the respective acid-base disturbances and shown that the center of the diagram represents normal. So if we look at a metabolic acidosis, we can see that the typical range of pH is lower than normal. If we look at the y-axis, we can see that the plasma bicarb is also lower than normal. And finally, the red lines that intersect with this region of the diagram show that the partial pressure of carbon dioxide is lower. I definitely don't recommend that you memorize this diagram. It would be much more valuable to understand normal acid-base physiology, and then you should be able to easily interpret it. I'm not going to walk through the rest of the acid-base disturbances on this diagram, but we've included it as a reference for you to review acid-base abnormalities and see the big picture. Ultimately, if the labels are removed from this diagram, you should be able to fill in the blanks by reasoning through the physiology we've just covered. In summary, let's review the major steps in diagnosing an acid-base disturbance. First, measure the pH. This will help you narrow down the differential to 2 of 4 major acid-base disturbances. Second, determine the partial pressure of carbon dioxide and bicarbonate. This will help you determine what the major acid-base disturbance is. Third, if there is a respiratory acid-base disturbance, make sure you check the pH and bicarbonate concentration to determine if the problem is acute or chronic. Fourth, if there is a metabolic acidosis, then check the anion gap and use the appropriate mnemonic. Fifth, use the Winter's formula for metabolic acidosis to determine if there is adequate respiratory compensation. And finally, if the patient has a metabolic alkalosis, be sure to measure urine chloride to help you narrow down the differential and aid in the treatment.